I'd like to welcome you all to today's webinar looking at how social and behavior change programs related to nutrition can adapt to COVID-19. My name is Lynn Van Lith, and I'm the Technical Director for the Breakthrough Action Project with Johns Hopkins Center for Communication Programs, and I will be moderating today's webinar. I've been lucky enough to work with and learn from the USAID Advancing Nutrition Project and colleagues there, and I'm really thrilled to be with you all today. So if we can move to the next slide. Today's webinar and most of the slides, apart from this one and the next, will be in English, but there is simultaneous interpretation into French. We're lucky to have Camilla with us today, and she will be translating for all of the French speakers. Before we start the webinar, everyone needs to select a language option. So please look at the bottom of your Zoom screen and locate the globe icon that says interpretation. Please select your preferred language, whether English or French, and if you are choosing French, you can click on the mute original audio if you don't want to hear the English narration in the background. Let's move to the next slide to also note that if you are on an Android or Apple mobile device, in your meeting controls, tap the three dots, then tap Language Interpretation. Tap English or French, and if you select French, please toggle mute original audio if you don't want to hear the English narration in the background. We ask that everyone please remain muted and keep your video off, just related to bandwidth. And if we can move to the next slide, just some final webinar logistics before we get started. This webinar is being recorded and is on Facebook Live as well. And just note that we absolutely will be sharing the recording, the slides, and links to all the resources that are shared today following the webinar. Everyone is on mute during the presentations, though there will be time for questions and answers at the end of all of the presentations. So please feel free throughout to add your questions to the chat box at any time, and we'll be tracking those and we'll try to get to as many as we can. Please feel free to add any comments or questions in English or French. And note that our colleague Jean-Jacques will be monitoring the Q&A box in the chat for any French questions, and will translate them for our speakers. So I think we'll be all set. So please feel free in English or French. The nutrition community is really coming together today and has been to explore, understand, and respond to the many challenges arising from COVID-19. We know that now more than ever, the role of social and behavior change is absolutely essential in supporting good nutrition. While key nutrition recommendations stay the same during the pandemic, we know that adaptations in SBC programming are needed to respond to the impacts that we're facing. Together, Breakthrough Action and the USAID Advancing Nutrition Project prepared two guidance documents, and you're going to hear more about those today. These documents are really intended to highlight considerations for program implementers and guide us as we move forward through the pandemic. On the webinar today, we'll share these and other resources and learn from experiences from practitioners in a few countries. Well, as I said, we'll have about 10 minutes for questions at the end. So again, please, you're welcome throughout to add any questions you may have in the chat box. And I'll note now, but return to this at the end of the webinar, that in 1 week's time, we will also be hosting a discussion on the Springboard platform, where we will really more deeply delve into the questions and comments and hear from other country experiences. We'll share more information, as I said, about the Springboard discussion at the end of today's webinar, and it will be held on August 6th. So just note that if there are any questions that we're unable to get to today, we will absolutely continue this conversation with you all on August 6th. So thank you everyone really for participating. And I think we can cover quickly the objectives here of the webinar that are threefold. First, to review the impact of COVID-19 on nutrition. Secondly, we want to highlight challenges and opportunities for nutrition SBC during COVID-19. And finally, we want to share experiences and resources for adapting nutrition SBC work during the pandemic with practitioners, as well as including information about how to manage disinformation and myths. As such, we will hear from several speakers today, and you'll see their faces on your screen. First, Jennifer Yourkavitch will provide some framing around the issue of nutrition during the time of COVID-19. Jennifer is the Director of Monitoring, Evaluation, and Learning for USAID Advancing Nutrition. Dr. Yourkavitch is an epidemiologist and lactation consultant whose research and applied work addresses social and structural determinants of health. She leads the project's COVID-19 task force and is investigating models of the impact of COVID-19 on nutrition outcomes. Next, Laura Itzkowitz, the Nutrition SBC Advisor for USAID's Bureau for Global Health, will provide an overview of the recently released technical briefs focused on SBC for nutrition during COVID-19, as well as the second brief focused on managing nutrition-related myths during the pandemic. Laura serves as USAID's SBC lead for the USAID Advancing Nutrition Project and supports the COVID-19 nutrition response. Lastly, we'll have three colleagues share country experiences with us, starting with Kelsey Torres. Kelsey is a project officer for SBC and nutrition and health systems at USAID Advancing Nutrition, who is leading activities to support quality SBC processes for improved nutrition and gender equality. We also have Dr. Nazgul Abazbekova, and she is the USAID Advancing Nutrition Project's Chief of Party in Kyrgyzstan. She is leading the scale-up of nutrition interventions and services using SBC approaches among many and is contributing to the COVID-19 response in close coordination with the National Ministry of Health. And last but not least, we have Kenneth Mulando joining us. He is the SBC advisor for USAID's Integrated Community Agriculture and Nutrition, or the ICAN project in Uganda. ICAN works with 8 districts to enhance the resilience of vulnerable households, including increasing consumption of diverse and nutritious diets. Kenneth brings with him a great deal of experience in social marketing, commercial marketing, and social and behavior change communication in Uganda. So with that, it is my pleasure to hand over to Jennifer of the USAID Advancing Nutrition to set the stage with an overview of nutrition and COVID-19. Over to you, Jennifer.
Thank you, Lynn. Hello, everyone. Salut. We can go to the first slide. Thank you. COVID-19 and nutrition. This is not a comprehensive list, but some main areas that we've been thinking about and observing from our field and country work. Weaker supply and less demand for nutrient-rich but perishable foods. We think of supply, labor and supply chain disruptions, and demand, consumption changes with pandemic containment measures that restrict movement, also restrict access to food. And this interplay of supply and demand disruptions affect food intake and ultimately nutrition status. Disruption in the delivery of essential nutrition services, in addition to routine health services, including family planning and immunization campaigns, which also indirectly affect nutrition status. More home births with untrained attendants increase the risk of maternal morbidity and mortality, in addition to non-immediate or exclusive breastfeeding, that pillar of infant nutrition. Disruption in income and social safety net. A Lancet commentary this week noted nutrition effects as household incomes decline and nutritious food becomes less available and affordable. Next slide. This is the key takeaway message from a modeling estimation published by a team at Johns Hopkins University in May. They found that reducing coverage of basic life-saving interventions in 18 low and middle income countries by 45% for 6 months could result in over 1 million additional child deaths, with about 20% of those additional deaths due to wasting. And another estimate published in a commentary just on Monday indicates a projected 14% global rise in wasting, which is an additional 6.7 million children with wasting during the first year of the pandemic, 80% of them in sub-Saharan Africa and South Asia. Next slide. Nutrition and gender. Women are particularly affected by the virus and the impact of containment measures. They make up 70% of the health workforce globally and are on the front lines of COVID response, increasing their risk of infection. At home, many women and girls face greater caregiving burdens and higher risk of interpersonal violence. UNFPA reports that the pandemic has disrupted efforts to end child marriage and female genital cutting, increasing that risk for millions of girls. Lockdowns to control the spread of COVID-19 have increased the risk of violence at home for women, children, and LGBTQ+ individuals. So that's some sobering background information on the state of things, but you'll hear more now about what we can do to address challenges and mitigate effects. Back to you, Lynn.
Great. Thank you, Jennifer. Thanks very much. And now let's move to our next presenter, Laura Itzkowitz, who will share the newly released technical briefs focused on nutrition-related SBC during COVID. Over to you, Laura.
Hi, thanks, Lynn. We can go to the next slide. So first I'm going to talk about some content from the technical brief on the guidance for SBC for nutrition during COVID-19. This guidance was prepared by Breakthrough Action and USAID Advancing Nutrition together and is available on the COVID-19 Communication Network website and also on USAID Advancing Nutrition's website. Next slide, please. Like all types of health and nutrition programmers, we as nutrition SBC practitioners need to identify and share solutions for extra challenges caused by the virus and containment measures. Some of the challenges we're seeing are that women and children may not be able to access nutrition services in a timely manner due to disruptions or fears. Providers may face difficulties providing quality nutrition services. There may be limitations in organizing peer groups and dialogue events, which we know are a cornerstone of nutrition SBC. There could be changes in patterns of communication and trusted sources. The high levels of stress and other mental health issues resulting from loss of social support structures and disruption may affect how families can practice recommended nutrition behaviors. Misinformation and rumors about food and drink can limit people's uptake of preventative practices and encourage harmful beliefs of cures. Next slide, please. Adaptive learning is really important to our programming, especially for SBC. So for us, these are not only challenges, but also opportunities. Before we start making any adaptations, it's very helpful to conduct a rapid assessment on how the nutrition service coverage has changed, how people in different areas and occupations have been affected by things like income loss, and what the government response has been to protect nutrition. It's important that we ensure that our adaptations to nutrition SBC or other nutrition activities are in line with the local context, the available services, and local government response. And of course, we must protect the safety and health of participants, health workers, community members, and project staff. In the next few slides, I'm going to highlight considerations for adaptations of 3 types of activities: capacity strengthening for nutrition services, community mobilization, and communication activities. There's no one-size-fits-all approach. Every context is different, and there could be contextual changes throughout the pandemic. It's important to regularly reassess the local situation and think about if new adaptations are necessary. Next slide. When it comes to services, capacity strengthening of health workers and community change agents should include how to continue to provide nutrition services while ensuring safety of themselves and others in response to COVID-19, with recommendations on physical distancing, wearing a mask or face covering, infant and young child feeding in case of suspected infection, and referrals for testing and social services. We often need to adjust how services are delivered to comply with physical distancing needs. For example, we might need to change training modalities to remote methods. And this is something that Nazgul from the Kyrgyz Republic is going to share how she's doing later in this webinar. We want to provide easy to use job aids. And one example of this are the counseling cards on infant and young child feeding and COVID-19 that can be adapted to your context that are available on USAID Advancing Nutrition's website. We may want to offer counseling through lower or non-contact means, such as telephone, internet, or home visits that are conducted outside of the home with some distance between the counselor and the people being counseled. If needed, We could increase the number of nutrition commodities dispensed at one time, such as micronutrient supplements for pregnant women, and include instructions of how to use them and when to return to the health facility. To help clients trust nutrition services during COVID, it's important to open regular dialogue between clients and providers so that the clients understand the changes in services and the providers understand the household's needs. We'd want to share any service changes with communities. So for example, if services have adopted measures to protect women during counseling, tell communities about these quality improvements so that they can feel safe coming to the facility. Next slide, please. When it comes to community mobilization and engagement, encourage communities to adjust activities according to local requirements for physical distancing. For example, when gatherings are limited, encourage peer groups to form smaller subgroups of household members or neighbors, making it easier to meet while maintaining physical distancing. Change how community activities are organized, from demonstrations or experiential activities to house visits by community outreach workers using masks or face coverings. Shift community dialogues to local radio instead and feature community leaders and change agents. Include options for two-way communication. Work through networks or associations with ties to many families to mobilize support for nutrition practices. Shift community gatherings to outside rather than inside a household or facility if gatherings are allowed. Establish a network of mentors or champions to continue mobilization efforts through non-contact methods, including phone calls, to ensure that supplies, information, and support are readily available in communities. Support community leaders to track the nutrition situation and identify households in need of referrals to social protection services, including food aid, in their communities and report back to households. Design triggers, reminders, and/or visual cues to encourage hygiene practices in communal locations, including signs for hand washing with soap at community water points. Next slide. So for adapting SBC communications for the COVID context, we might want to consider using remote communication channels like telephone, radio, TV, and social media to continue promotion efforts through non-contact methods that target the first 1,000 days. And Kenneth from Uganda will share about this next. You can think of pre-testing new messages, materials, and interventions using virtual channels such as WhatsApp, Facebook, YouTube, WeChat, Instagram, and TikTok, because we all know that pre-testing is important and that has not changed because of the pandemic. There are some resources on the COVID Communication Network, a virtual pre-testing technical brief and tips for engaging communities during COVID-19 in low resource settings, remotely and in person. So you'll want to modify the content and increase the promotion of existing health hotlines and other digital and mobile services, such as the 321 lines, WhatsApp and Facebook, and SMS or interactive voice response that already exist to ensure audience members can access key recommendations and counseling on nutrition information, including breastfeeding. Use virtual training to strengthen hotline counselor and staff capacity to make referrals to resources, including social protection services. You can establish a national or local repository that collects misinformation circulating about nutrition and shares with authorities and change agents to address this regularly. For communities, this can include concerns about stigma and discrimination toward people who are at risk of infection for community action. Next slide. So, based on the local situation, messaging may also need to be adjusted. The content might need to be adjusted with the prioritized behavior recommended, or how to do the behavior may have changed, or how to make it possible in the situation, such as engaging family support. There are a number of examples in the guidance on how to do this. As per SBC communication best practices, all messages should be adapted to local country contexts, local policies, and prioritized audiences. Next slide. So now I'm going to talk about some of what you're going to find in the brief on managing nutrition myths and misconceptions during COVID-19. This was just posted yesterday on the COVID Communication Network website and should soon be posted on the USAID Advancing Nutrition website. It was also developed jointly by the two projects. Next slide. When it comes to managing nutrition misinformation, trusted authorities should provide continuous, accurate information about nutrition in the context of the virus with the most updated information available. As we know well in SVC, information is most effective when tailored to people's values, presented as concrete actions that people can act upon. Next slide. But if misinformation has the potential to cause serious harm, trusted authorities should address it carefully without giving further attention to the rumors. Research shows that talking about misinformation, even when well-intentioned, can sometimes make it worse by giving it room to grow. A common issue going around in many countries is an over-reliance on one superfood, herb, or drink that people think can prevent or cure COVID. When dealing with this, you want to state the facts without repeating the misinformation. So one example might be, lemon juice does not prevent COVID-19. Good nutrition cannot prevent COVID-19, but can support a healthy immune system. However, a single food alone is not enough. Eat a variety of food, including fruits, vegetables, and animal-sourced food. So that reinforces key nutrition messages while counteracting the misinformation, but not repeating it. So another example, where diets are already lacking in key nutrients, concerns around contracting COVID-19 through fresh fruits and vegetables that may be contaminated could lead to reduced consumption. So you may want to respond saying, fresh food is safe to eat. The virus is not passed through food because the virus does not stay on surfaces long. Feed your family vegetables and fruits every day as part of a healthy, diverse diet for good growth. Next slide. Incorporate media literacy into ongoing nutrition community activities and media so that people can be savvy about what is fact and what is rumor or fake news. To help people think more critically about what they hear, teach communities and individuals as part of peer groups or via local media about the actors who are spreading rumors and their motivations, such as making money. You can find more details and illustrative examples of all of this in the two briefs that I mentioned and that will be linked later in the slides. Thank you. So next slide.
Great. Thanks very much, Laura. Thank you indeed. And a reminder to please add any questions you may have in the chat box, and we'll respond to those after our next session here. So it is my pleasure to now introduce the portion of the webinar focused on sharing insights from country experiences. So as already introduced, Kelsey, Nazgul, and Kenneth, I will hand it over to you.
Great, thanks, Lynn. I would like to thank Jennifer and Laura as well, who have framed this discussion so nicely. During this next segment of the webinar, as Lynn said, we will be learning from our in-country colleagues about their experiences with the impacts of COVID on nutrition programming and adjustments they have made to mitigate disruptions in nutrition programs and services. Many thanks to Nazgul and Kenneth for their willingness to share these experiences during such a challenging time. We will start with Nazgul, who will share how in the Kyrgyz Republic, USAID Advancing Nutrition has adjusted nutrition trainings and supportive supervision for remote participation of health workers and made adaptations for counseling on nutrition. Over to you, Nazgul.
Thank you, Kelsey. Good morning, everyone. I'm going to share the experience of Kyrgyz team of the USAID Advancing Nutrition Project. The project works in the Kyrgyz Republic to improve nutritional status of women of reproductive age and children under 5 with specific focus to 2000-day window of opportunity. Working in partnership with national and local governments and health centers, village health committees, and local and international NGOs, the project promotes nutrition practices through social and behavior change approaches and improving health services and health workers' capacity. Next slide, please. Advancing Nutrition in Kyrgyzstan started its operation in February of this year. The first cases of COVID-19 were detected in country in mid-March. Authorities in the Kyrgyz Republic quickly introduced lockdown of the entire country and declared state of emergency. With the community transmission of COVID-19 rapidly increasing in the country, we end up with an almost 2 months of period declared state of emergency. These conditions have resulted in delay of many activities. In May, government eased lockdown conditions, which in mid-June resulted in rapid increase in COVID-19 cases, causing very high level of morbidity and mortality. According to WHO, as of today, we have more than 35,000 confirmed cases and over 1.3 thousand deaths. Next slide, please. Our staff members are mandated to work from home and continue to engage with each other and partners remotely. Despite these challenging conditions, the project made significant progress in moving forward with activities and was able to complete some of important accomplishments, such as signing of bilateral memorandum of understanding between the project and Ministry of Health, which provides blanket approval for our project approach and main activities. The project also expanded its operations in the field office in targeted Abazbekova region and have made adaptation to our approach to both facility and community level activities. Here you see our typical SBC approach, which involves training volunteers. We call them activists on a different nutrition and hygiene topic each month. Those activists then engage with their communities through targeted household visits and community meetings. Next slide, please. And here you can see the changes in our approaches. With the anticipated longevity of COVID-19 restrictions on travel and gathering in groups, the project reorganized its SBC activities in a way that the recruitment and capacity building of community volunteers and nutrition information dissemination activities will be conducted in an online format. We conducted the recruitment of volunteers online. Our activists will use WhatsApp to conduct virtual household visits, and they will share information and educational materials virtually rather than in hard copy. Additionally, nutrition topic-specific modules are under significant revision. Each module will be enriched by visual materials like animated videos and infographics. Each month, activists will be trained on a topic to be delivered and disseminated within their communities, specifically targeting Southern Bay households to address malnutrition issues. As a result of USAID Advancing Nutrition Support, Kyrgyz Republic has revised and improved national technical guidelines on the infant and child feeding program. In addition, IYCF COVID-19 key recommendations booklet and COVID-19 counseling package was translated to Russian and Kyrgyz languages and will also be disseminated to targeted health providers. We work to adapt 5-day in-person IYCF training to a virtual platform. TOT for national trainers was provided online. We plan to conduct cascading training on IYCF for more than 300 medical workers in the Batken region. Following the IYCF cascade training, the project is planning to gradually start virtual supportive supervision activities. In-person supportive supervision will not be conducted until it is safe to do so, given the rapidly changing COVID-19 situation in Kyrgyzstan. By this, I'm concluding my presentation. Thank you.
Thank you so much, Nazgul. You've described some really thoughtful, innovative, and creative adaptations. And now I'd like to turn it over to Kenneth. Kenneth will tell us about how USAID ICAN in Uganda has been able to engage communities during COVID-19 and has promoted new or adjusted nutrition behaviors due to the changing situation?
Thank you once again. This is Kenneth. I'll tell you a brief about ICAN. ICAN is a integrated, USAID integrated community agriculture and nutrition activity. It's the nutrition flagship project that is designed to reach 185 households with women of reproductive age in 8 districts. There are some keywords that I would want to tease out at this point. One, it's a resilience project. What does that mean? That we planned for such shocks before comprehensively. Secondly, the other thing I want to tease out is that it's an integrated program or project that has livelihoods, has food security and nutrition, and governance. With all those advantages, I wanted to raise, to move to the next slide, please. ICAN has partners. As you can see, the lead partners are Apt Associates. Then we have local partners, Caritas and the Children of the World Foundation. And we have other partners, technical partners, Making Sense, Manoff Group, and Mango Tree and Saltec. Next slide, please. I talked about ICAN being a resilience project. And one thing I wanted to bring out now is that we have what we call community resilience planning. And this is a process that we go through in all the communities that we work in. So one thing that we do, we have communities are able to work and identify influential parties or stakeholders within the community. And then they mobilize themselves to discuss things that will build resilience. And they have come up to describe 5 things that they actually think will build their resilience. Things around education, food security and nutrition. Then they also talk about WASH. They talk about income generating activities, and they talk about natural resource management. So 5 things that communities have identified and said, if we work on these 5 things, we should be able to have a resilient community. So out of that, they go back and identify what are the possible shocks that can occur or happen in regards to our 5 things that we have identified as resilience points. And they come up with plans on how to mitigate and address those shocks. From that, they're able now to implement their plans they've come up with to mitigate or respond to possible shocks. And they do that and have accountability that goes on as they do the implementation. From that, they finally have a resilient review as a community, as they sit back and say, are we resilient? How are we doing with our resilient plannings that we came up with? Can you move to the next slide, please? Next slide. I'll tell you something that, So I'll tell you something about what we did before COVID. How did SBCC look like? So SBCC was being done through collective engagement, through mother care groups, farmer groups, and other community groups, usually with about 15 to 20 people converging to come up with priorities. Those small groups had 15 to 20 members. They had demonstration farms running under the nutrition component and also the livelihoods component. Then we had dialogues happening under the governance arm, and we had 10 to 20 leaders sitting and coming up priorities for the communities. Upon that, they would go ahead and share their priorities with 100 to 200 people in big gatherings, which we called community barazas. Then we had running tactical campaigns, which were basically thematic and addressing specific issues. On top of that, we had radio programming, which was just an overarching support in regards to the activities which are going on. Now, with COVID, we had to look at some key considerations and how best do we adapt. 1, radio is still lead in Uganda with 89% listenership. Mobile phones, ownership is at 60%. The government continuously issues guidelines, and they kept on issuing guidelines. The first, they accepted people to converge in groups of 5 people with social distancing. The government still prioritized agriculture production and nutrition as key things, as essential things that should be going on. Next slide, please. Next slide. So with COVID, what happened? Now we had to shift gears with those considerations. One, we had to start off with SMSing, sending messages to phones to key champions. These are people who actually reach out to the communities. For the livelihoods component, we work with the business service providers. For nutrition, we had the village health team members, and governance, we had community leaders. So the messages focused on driving actions aimed at encouraging the champions to promote key messages to the community members. Then we had we introduced radio-based community dialogues. Remember, the government allowed us to have dialogues of 5 people. So 5 leaders would converge and discuss key issues and agree on priorities. And this was recorded and aired on radio for a larger community with a call-in opportunities. So the call-in replaced what we had as our barazas, that now we're talking to a larger community beyond the 100 and 200, we're talking to a larger community and people are listening in. Then we introduced megaphones in one of the regions to replace the community meetings and relied on home visits or garden visits instead of the group meetings that we're holding, that an individual would visit, a key champion would just visit an individual home to demonstrate that. Then we introduced, for our monitoring and tracking, we introduced a community SMS and radio tracking tool that captures immediate feedback from the community members. Next slide, please. What behaviors are we looking at? Nutrition behaviors promoted. One, I shared that ICAN is a resilient project, deals with resilience. So COVID-19 was a shock. So the key responses that people wanted to pick at that point when we saw COVID come up. So one of them was, what should I do? It was a big question coming up. How do I do it? And those were the things coming up from the communities, that government has issued guidelines. COVID is real. How do we respond? So the nutrition behaviors that we came up with were made to respond to that shock and timed. So some of the messages we came up with are behaviors that we're promoting: continuing cultivation of hunger food crops while observing the guidelines which had been issued. Access to improved inputs. We came up with a system just beyond the messaging, where we had the motorcycle system that people could order for inputs, agro inputs, and the agro inputs could be delivered to their doorstep using the motorcycle system. Then safely storing food. That was something we promoted. How do we actually handle post-harvest handling? Responsibly saving, use your savings. We promoted the using of savings. Then put up and use wash facilities. That's something we promoted. COVID brought up, people focused on wash a lot, and we also tried to promote it as ICAN being part of resilience planning or implementation. Then feeding a sick child between 6 to 23 months. And that's something we also emphasized and promoted, because at the time of COVID, it's again the cycle time when we have a malaria peak, where malaria picks up in Uganda. So we had to promote how to feed a sick child between 6 to 23 months. Then we continue to prioritize the livelihood and nutrition behaviors while observing the specific guidelines which had been issued. We also try to strengthen resilience required for social change, and through accountability processes of community resilience plans that we developed, and I mentioned in the first slide that they actually came up. We have community resilience plans, and these are continuously being implemented. And then we have accountability being a strong component. So even amid this COVID, we try to emphasize, all people, communities try to emphasize, how do we remain accountable to the change and the resilience plan that we developed before COVID. So those are the brief, next slide please, that I wanted to share around ICAN in Uganda. Thank you very much.
Thank you, Kenneth, for sharing your experiences engaging communities and selecting or adjusting behaviors to focus on. I would like to thank both Kenneth and Nazgul again for sharing their impressive experiences navigating such a dynamic and unique situation. I would also like to recognize their hard work and the hard work of their teams that went into these creative and nimble programming adjustments. And I will pass it back to you, Lynn.
Great, I agree. Thanks so much, Kelsey, and thanks Nazgul and Kenneth. We are actually going a little bit ahead of time, which is wonderful. It means we'll have a little more time for questions. And with that, Kenneth, maybe we can start with you. We're not going to go in the exact order, but there are a few that came through while you were speaking. Related to the work that you're doing in Uganda. And you had mentioned a radio tracker tool. How well is it working as a monitoring tool? And can you share a bit more about that?
So the radio tracker, it's radio and SMS, tracking both because that is the main media that we are using at the moment. So what the field officers who work for our partners are able to go to the field and actually ask questions around who listened, what message did they pick, what feedback do they have around the messaging. So it's more of your process kind of monitoring to just gauge the penetration of the messaging that we're pushing out, and also the acceptability of the messages that we're putting out. So it gives us a kind of feedback that we're able to rely on to make improvements before we disseminate the next messages. So it's a brief tool just capturing it's more of a pulse check that gives us a feel of what's happening in the field in terms of the messages that we are pushing out. Yeah.
Great, thanks, Kenneth. And while we're on this topic and thinking about remote or more virtual approaches, perhaps Kenneth and Nazgul, you can respond to the next question, which came in French. What are the limits of turning to online resources for transmission of information, training, and visits? There are some questions here about, whether or not households have easy access to the internet. And further, I think an attached question is, what are some of the trade-offs or the compromises when you move to more of those sort of virtual approaches? What are the challenges that you've encountered, whether it's related to the quality of data or trainings when using these virtual channels? So Nazgul, would you mind? I know that's a lot, but if you can start and then Kenneth can respond after you, please.
Okay, thank you. You're right. Virtual trainings in case of health providers training, they doesn't allow for practical session on counseling. And to solve this problem, the project decided to conduct additional training on counseling or spending additional time during supportive supervision visits, also virtual, to ensure the skills is obtained. Making a determination about additional training will be a consultative process. We will share plans for future curriculum development with key partners and ministry stakeholders to streamline the required technical review and the approval. This is the first time when all trainings, not only by our project, by other projects as well, are conducting for health providers virtually. And even supportive supervision visits, they are also provided virtually. That's why we will decide later on how we will streamline this activity, but we are planning practical sessions as well on counseling.
Great, thank you, Nazgul. Kenneth?
Just a couple of challenges. One, we looked at most of the nutrition messaging is or communication requires a bit of experiential input. We need to do demonstrations. We talk about, and those were limited totally because we are relying more on SMSs, which is just a message on the phone. Then you're also having a VHT not being able to meet the people as they used to meet in the mother care groups where they could share different challenges and experiences. So those were some of the challenges that we could have experienced. The other one was I mentioned phone penetration is 60% in Uganda, or ownership is 60%. So you could imagine that some of the communities where we work may not be having access to the phones that we are relying on to send messages. So those were some of the challenges we have experienced. So, and the biggest trade-off has been us saying, let's go with what's available, and we see how we're actually able to see how we're able to see the response for them. That's why we introduced a tracker, just to mitigate and find out how well we're doing with our messaging in the communities.
Great, thank you, Kenneth. Thanks for adding that clarification. And one last question here for both of you before we switch gears. There are a few questions about, Nazgul, for you, of how you ensure that the virtual visits through WhatsApp, trying to figure out what are the specific techniques you applied. And another question here around training of health workers and volunteers, that some of these virtual platforms have time limitations. So how are you managing some of those kind of tech side of things?
Okay. For first question, how we are using WhatsApp for visits, like support supervision visits or post-training visits. Before engaging into the trainings, we project made a research of how many providers have WhatsApp applications, and it turned about 95% of providers, they have access to WhatsApp. And we have a good number of national trainers who are engaging during counseling of mother, and providers, they switch on their WhatsApp and they are providing services, how to say, in online format. And mentors, they can observe and give feedback and recommendations. And the second question was, excuse me, can you remind me?
Just more related to how you're using the specific approaches for virtual, on your virtual platform, is very similar to what you've already addressed.
Yeah, so it's time limitation. So we are planning our trainings for 3 hours a day over the course of 3 days. And prior to each session, participants receive reading assignments via email or WhatsApp. And this methodology was tested during TOT in July and was successful.
Excellent, thank you. Kenneth, do you have anything to add around some of these challenges with virtual platforms?
Of course, as my colleague has just shared, I think those challenges continue to one, we don't have that good internet penetration. Internet in Uganda is just about 10% of 10 to 15%, between 10 to 15%, which makes it a big challenge. You cannot rely on those virtual platforms. And we have the literacy challenges that not everybody can read and write in Uganda, especially in the rural communities where we work. So that's also one of the challenges that we see with the virtual platforms, that when you send a message, of course, you can't send it to the mother because the mother won't be able to read it. Most likely the mother doesn't even have access to the phone to be able to access the messages you're sending. The phones are actually owned by the men in most of the communities. So all those are challenges that we are seeing with those virtual platforms, that how do we actually deal with gender equity when it comes to using virtual platforms, and we haven't had good success in that area. Maybe this is something that we could actually think about moving forward in the future, how best we can build that penetration within the rural communities. Thank you.
Thank you, Kenneth. And that does tie into another question that came through in the chat box related to questions of literacy. And, do you have any examples of using images or things that don't require high literacy to still convey the messages? I don't know if either one of you have some of those examples to share.
So prior to COVID, yes, we did have, we didn't actually have, we had the physical print materials, but we haven't really used the virtual materials or videos because internet penetration is not as good for rural Uganda. So even the mobile phone or smartphone ownership is very low in Uganda. So it's not something that we have considered in Uganda using those video messages or even images to actually shown on the virtual platforms. We haven't succeeded in that area. My colleague can share.
Nazgul, would you like to respond? I see that Lisa has also weighed in the chat box that you are indeed using some images quite creatively. Do you want to share something related to shifting to phone apps?
Is she still on?
Nazgul, maybe she's muted.
Oh, sorry.
No problem.
Yeah. Most of our SBC materials were transformed into the online or into the like animated videos and infographics, and we are still in the process. So for example, for the first topic, we already have prepared and ready to share. I wanted to add that it was a good will of one of biggest mobile companies in the country when we experienced very how to say it's like a peak of pandemic and a lot of it was very hard time a few weeks ago. So this mobile company, they provided free internet for all health providers for entire country. And this also allowed us, this will be supported for several months ahead. And this also allows us to use our platform to complete our trainings for health providers, as well as for activists, for our volunteers. We are charging units for internet, for mobile internet.
Great, thank you, Nazgul. Thank you very much. Let's move to a next set of questions really more related to social and behavior change practices more broadly as they relate to nutrition, and I welcome any of the presenters to respond. We have a handful of questions here around how do we make mass communication two-way, and I see that Mary has started responding in the chat box, so thanks, Mary, and she mentions WhatsApp, texts, small gatherings, and of course the importance of using multiple channels for communication. Other questions around how do we increase media literacy, and with so many messages floating around, be it through social media or otherwise, how can we make sure that the accurate key messages are not lost in the mix? So I open it up to any of the presenters who would like to speak a bit more broadly to the SBC concerns raised by the participants.
I can start out on that. So in terms of making media two-way, as Mary had mentioned in the chat box, but you want to direct people to where a conversation can happen. And so whether that's through radio, could be call-in and having people call in with questions to have a conversation. It could be that you do a radio campaign that directs people to a WhatsApp group or to community events or to a community leader they can talk to, a community health worker, but really thinking through how can you use the media both to get across a single message and also to guide people to where there can be that two-way communication.
Thanks very much, Flora. If there aren't any other additions, maybe we'll go back to a question that came in quite early from Julie from the GFF, asking about monitoring the nutrition situation in various countries. And Jennifer had responded in part in the chat, but Laura or others, I don't know if you have any other information related to monitoring and how that is looking in the current pandemic.
So I know that this is happening differently in different context based on the situation. And so I think there's not, this is where, when I said there wasn't a one size fits all approach, I think with monitoring especially, it's really hard to say that here's a specific way to do this because it's going to really depend. I know there's been some push toward training mothers at how to do those measurements, and so that a community health worker or a data collector could be there, but keeping physical distance while the mother measures the child and weighs the child. So that's one example, but then it would still get recorded and reported the same way. And then I'm not sure if others have other examples of how this might have happened in different countries.
Thanks very much, Laura. Nazgul or Kenneth, do you have anything to add from your country-specific situations? If not, we can move to our last question.
Well, this hasn't yet happened, but it's some thoughts on the table that people shared. How best can we introduce, build the capacity of the mothers to do their own use of the mock tips and see whether they can actually do the measuring themselves and know how to use the mock tips. And I know it's one thing that has been put on the table in Uganda, that can we actually move it away from the village health team members, which is like our first health center point, to actually have the mothers do it themselves. The other thought that has been brought on the table is introduction of the length mat, again at the household level, but these are just thoughts, and we haven't yet really implemented them, but they're thoughts that people have brainstormed about, and they're thinking this is a way to go to just be able to know the actual situation around nutrition during this COVID period. Thank you.
Thanks, Kenneth. Given that we are a bit short on time, I guess one of the other questions that we can ponder before we all come back together for the Springboard conversation is really, given some of the issues raised here, how can we ensure that everyone can benefit from interventions, even when there may be challenges for accessibility and ICT use and media literacy across the board? So we'll hold that. And thanks to Jennifer, she's also responded to a few additional questions in the chat box. And I see that others are sharing information. So thank you so much. Let's move to the next slide. I want to really thank all of our presenters. As mentioned and already shared in the chat box, both of the technical briefs, as well as there are others on virtual pre-testing and so on. Those are all captured on the COVID-19 Communication Network. And this website listed there, you'll see the link, is a curated set of resources. There are now over 350 resources, including images for low literacy populations. And Marcella has just put it in the chat box. So I invite you to go there to check for other resources. Next. And as a reminder, there are all of these other online resources that are captured in both of the technical briefs. So you can absolutely access more information there. And next. I promised at the beginning to come back to our plans to continue this conversation with you all and others on Springboard, which is another virtual platform really designed for social and behavior change professionals, open to anyone. So next week on August 6th from 9 to 11 Eastern Time, we will carry on a conversation and invite all of you to continue asking questions, and absolutely please share your country experiences so we can all learn from one another. You'll see the link here, springboardforsbc.org, if we move to the next slide. The Springboard membership is over 3,000 members now from over 90 countries. And please, for those French speakers on the line, you are also very welcome. Lots of the experiences and conversations are translated there in French. And if you go to the next slide, you'll see a link. Actually, it's the one after this. Let's just move to the next one, please, Marcella. Yes, for joining Springboard, you'll see this on your screen when you go to enter, when you click on how to join. And you just enter a few pieces of information, send that in, and you will be approved to be a member of the Springboard for SBC.org. So on the next slide, you will get this email back saying that your application is completed and that you are now part of the community. So please, everyone, we hope to see everyone there. Lisa has chimed in as well. Thank you. And last slide. Yes, just to thank again all of our presenters today and to all of you for joining during these sort of crazy times. We appreciate the questions and really look forward to ongoing conversation. Special thanks to colleagues from the USAID Advancing Nutrition, Kelsey and Lisa, and of course Laura, as well Camila for her interpretation today, and to Marcella for managing today's webinar. We greatly appreciate it. You will see that there is a set of poll questions in front of you. If you can please address those. For those of our participants in French, we will be sending out this survey in French as well after the webinar. So please do take a few minutes to answer those poll questions. With that, I just want to pass it back to Laura for your closing comments. Thanks again.
So I just wanted to say thank you to everyone for joining. It was so great to see almost 300 people on here, and I know I saw a lot of familiar names on there. So to everyone who I know, hello. Hopefully, I know there were a lot of questions we didn't get the chance to answer, and we're going to try to get to those next week on the Springboard discussion. So I hope you can please join us then, and thank you again.